Today we are unpacking Andrew Huberman's Huberman Lab episode on autism. I'm Carrie Sousa Woodward. I'm a board-certified behavior analyst, and I've been working with autistic children and their families for over 20 years now. Now, if you're not familiar with the Huberman Lab podcast, this is a podcast and a YouTube channel that's dedicated to providing science to everybody. Andrew Huberman is a neuroscientist out of Stanford University. It's an amazing podcast and YouTube show, and I really highly encourage, if you're interested in science, that you check it out. But they recently did a whole episode on autism, and I loved it so much. It's so technical and it's so scientific that I felt like it would be super beneficial to sort of break it down, discuss the different topics that they are going over in the podcast, and really trying to make it as simplistic as possible so that all parents and all people who are impacted by autism can understand and appreciate where the science is today about autism. Dr. Huberman's guest on this episode is a woman by the name of Dr. Karen Parker. She is also a scientist out of Stanford University, and she studies the biomechanisms of autism. And what this really means is, what are the markers that may predict autism from a biological perspective? Not necessarily how the environment impacts, but just what biological mechanisms there may be to be responsible for autism, and how we can use those in sort of guiding what treatment can look like in the future. I want to just say something quickly about the terminology, because I go back and forth between person with autism and autistic person. And that is just because the way that Dr. Huberman and Dr. Parker are discussing it, also they go back and forth in their terminology. And this is because there is a push in the autistic community for identity first language, because there is a strong sense that autism is not something separate from them. So person with autism sort of makes it seem that it's this separate piece from them, that it's a disability that's separate from them. Most autistic people who are in this camp think about it as being very much a part of who they are and cannot be separated from them. And so they prefer being referred to as autistic, not person with autism. There is a large majority of parents with young children who are highly offended by the use of the term autistic and prefer person with autism. So you're going to hear me go back and forth. I don't think there's the perfect way that it can be done, because either way it's going to offend one group. I tend to prefer to use autistic because I highly respect the autism community and I don't want to offend them with the wrong use of terminology. But you are going to hear me go back and forth between these two different ways of describing it. One of the first questions that's discussed is this question of whether or not the incidence of autism is increasing, or if we've just gotten better at detecting and diagnosing autism. If you've been in the autism field for a while, you know that the incident rate, or the number of people that are diagnosed with autism as compared to the neurotypical population, has gotten significantly higher over the last 20 years. I've been in the field for over 20 years now. When I first began, I remember sitting in one of my first trainings, and I think the incidence rate was like 1 in 450 kids were getting a diagnosis of autism. Today, it's 1 in 36. And for a long time, there's been this debate of, have we just gotten better at finding, detecting, and diagnosing autism, or are we actually seeing increased rates over time?
Do you have any clear answers to that?
Well, I think it's a multifactorial answer. So we're getting better at detecting autism, right? So in the past, we were diagnosing kids at 9 or 10 years of age, right? And now clinicians are able to reliably diagnose kids at 2 to 3 years of age, right? So there's more people. There are pediatricians have autism screeners now. So when you bring in your baby and over the first couple of years of life, you're filling out screeners that are looking for autism symptoms, right? So there's just a lot more awareness around autism. But the rates have increased to now 1 in 36 U.S. children have a diagnosis of autism, which is over 2 years ago, it was 1 in 44. So
1 in 36.
Mm-hmm.
Essentially, we have gotten significantly better at identifying what the symptoms are, identifying the characteristics, being able to identify these kids and adults who may have missed a diagnosis earlier when they were younger. And so we've gotten better at detecting and diagnosing autism. However, the incidence rate is increasing even beyond just what's being detected and diagnosed. We don't know why. There is significant evidence to support that there is a lot of interaction between genes and environment, And that's this combination that is spurring the increased rate of autism diagnoses. The only empirically based and supported method of treatment for people with autism is behavioral intervention. And he asks how early or how young is too young to begin behavioral intervention.
We're going to talk a lot today about interventions, but how early are some of the behavioral interventions? And I should just say any interventions introduced nowadays. So if someone brings their child to the pediatrician and they take one of these tests and that a child is deemed as having autism, will the 1-year-old or the 2-year-old immediately go into behavioral interventions?
Well, so usually you need to have the diagnosis of autism, and then there are behavioral interventions, or a variety of different ones that are used. There are some studies where because autism is highly heritable, you can have one child with autism, and then if you have subsequent children, you're at an increased risk of having subsequent children with autism. And these are called baby sibling studies. So what you're doing is enriching the population of infants that you follow prospectively who are more likely to receive an autism diagnosis. And there are studies where some of those children are enrolled in behavioral studies even when they're quote unquote at risk.
And I love this question because the earlier we can begin behavioral intervention for kids, the better the long-term outcomes. And this stems from the idea that the neural plasticity, or how adaptable the brain is to change, is the highest between birth and age 3. This means it's the easiest to try and secure the right neural pathways that are going to provide for the most adaptable behaviors, the behaviors that are going to make our kids the most successful. And it happens the quickest, the easiest between birth and age 3. So when we talk about how young is too young for a behavioral intervention, we really are hamstrung by the idea that we cannot provide diagnoses to kids until at least 2 years old. And this stems from the fact that the diagnosis is a behavioral diagnosis. That means that the child must be exhibiting observable behaviors that align with the diagnostic criteria as it's outlined in the Diagnostic and Statistical Manual, the DSM. This is what professionals and experts use in order to make a behavioral diagnosis. You see, even though we think that there's a genetic foundation for autism, there's not just a simple blood test that can be taken in order to determine whether or not somebody might have autism. And so we're left to be able to make this behavioral determination. And the behaviors just aren't strong enough. We don't have diagnostic criteria that is solid enough in order to diagnose children younger than about 18 months. This means that our window for brain plasticity has become increasingly smaller because we don't actually get a formal diagnosis until around 18 months, if not much later for most kids. Dr. Parker is discussing how there is research being conducted on providing behavioral treatment intervention to younger siblings of children who have already received a diagnosis. Because we know that autism is highly genetic, so there's an increased chance that a younger sibling is also going to receive a diagnosis of autism if their older sibling is autistic. And so in this research, what they're doing is they're essentially providing behavioral intervention to kids who don't yet have a diagnosis, but have a higher probability of receiving a diagnosis later in life, to see if some of this really early intervention can be beneficial in helping to ameliorate symptoms in the future. And I love this research because this is exactly my idea. If we can identify when there are delays present for kids, we're questioning whether or not autism might be in the future for a child, that we could actually begin targeted intervention and early intervention for these kids while they're going through the diagnostic process so that we don't waste time when the brain is in the perfect place to have significant change happen. Okay, they then jump into this idea of the spectrum, right? We know that autism is a spectrum disorder. It means that there is a wide array of symptoms and severity. And what I love is the elegant way that Dr. Parker sort of describes it.
Talking about something that's in multiple dimensions and not just one line that goes from severe to mild. Does that make sense?
Because autism is highly heritable, so there's about 40 to 80% of autism is genetic, right? So these vary wildly, right? But the common thinking is that the majority, about 50% of autism, is associated with common genetic variants. And so the way that we've always thought about this is that there is this, autism is largely an inherited polygenic condition. But what I mean by that is that you have a lot of common variants that are additive. And so if you think about this collection of common genetic variants that underlie this spectrum, right? So if you have less of a dosing of some of these common variants, you might see somebody who's who's higher functioning, like you said. And if you end up with one of these single gene, highly penetrant disorders, you might see severe intellectual disability and sort of lower functioning on the other end of the spectrum.
So she talks about autism being incredibly heterogeneous, and this means it's just very different. If we think of something that's homogeneous, that would be something that is similar across the board. Everybody who has it displays very similar symptomology. And what we know about autism is that is just not the case, that every single child presents with very unique characteristics and different severities. It's hard to say this is autism because it can be so different in every person. There's this graphic that I've seen on the internet because essentially when we think of spectrum, we think of something linear. We think of severity from mild to incredibly impacted by autism. But there's this graphic that essentially puts like a spherical display of all of the different areas that could be impacted by autism. And it varies across all of these different dynamics for each person. And that's why no one person's autism looks identical to another person's autism. And the way that Dr. Parker describes this from a biological perspective makes so much sense. Polygenomic, which means that there are multiple genes that could be expressing different levels that all kind of work together in an additive way to create autism for a unique individual. And so if we think about multiple genes, and it requires multiple gene variants in order to get this diagnosis of autism, but that the variants can somehow impact severity levels. So she's talking about how maybe one genetic variant might be more detrimental than another genetic variant. And so it depends on which genetic variants are happening for each individual person. If you have a lesser dosing of these genetic variants, that might contribute to having a more mild version of autism. So Dr. Parker and Dr. Huberman spend a significant amount of time talking about the social aspect of autism because inherently there are two pieces to an autism diagnosis. One are deficits in social interaction and social communication. Communication is an inherently social behavior. Communication doesn't exist if you don't have a social community around to be able to reinforce your communication. But there's also this other aspect of autism, which is the repetitive or ritualistic behavior. And this is sort of those stereotypical behaviors that you see: hand flapping, spinning, waving fingers out of their eyes. And so this discussion in the area of research that Dr. Parker looks at is really just focused on the social aspect. So it's not ignoring this piece about autism in the repetitive ritualistic behavior. However, this is really solely focused on the social aspects of autism.
This is being social is actually one of the core characteristics of our species, right? So social interactions are rewarding from infancy. They keep us alive, as you mentioned, right? And so I think it's not an accident that the way we think about disorder in our species is many disorders are disorders because of lack of social connectedness, right? So it could be something like autism where, there's these pervasive social interaction impairments. It could be something like drug abuse where a risk factor for drug abuse is feeling, socially disconnected and alone, right? Social isolation or loss of a loved one is a very strong predictor of the onset of a stress-related depressive anxiety disorder.
In terms of,
I love this section so much because it really sort of highlights the reason that social impairment is such a problem. Social interactions are rewarding from infancy. And I think that this is so profound because when she talks about rewarding, from a behavioral perspective, we would consider that reinforcement, right? Reinforcement is a consequence that strengthens behavior, and reinforcers are those things that are presented following behavior that have a strengthening effect. The reinforcers draw our attention. So we pay attention to reinforcers. We look at reinforcers. And when reinforcers are present surrounding our behavior, that behavior is strengthened, increased, improved. And when we're talking about social interaction being rewarding or reinforcing from infancy, This is not the case for autistic infants. And we don't necessarily know why, whether they are just not drawn because there's no inherent interest there, or they don't serve as reinforcement, and so therefore they spend a lot less time looking. But this is sort of where the social deficit begins for autistic children in infancy, because we know through infant research that it's from a very young age that autistic infants are looking at different things than neurotypical infants. They are spending a lot less time looking at people and social things and a lot more time looking at tangible items or objects. And this is a twofold situation because we are drawn to look at things that reinforce us. And when social things reinforce us, that behavior becomes strengthened. So when you have infants that are not drawn to people and looking at people, and then are therefore not even sensitive to social reinforcement, they're not going to be picking up on how to learn social behavior. They're not watching it. They're not going to observe it to imitate it. And social consequences don't serve as reinforcers for autistic babies. And so then that is going to further hinder development in learning because we use social consequences as reinforcement with our babies. Social interactions keep us alive. So Dr. Parker's history is in evolutionary biology. So she studies really how evolution has sort of shaped the different social behaviors that we engage in, why we engage in certain behaviors from an evolutionary perspective. And this is one of those, that social behavior has kept us alive as a species. It's inherent in forming relationships and connections, which is what we need in order to procreate and continue to pass on our genes to the next generation. If all social behavior were to become deficient and impaired, our species would most likely perish. There's safety in social behavior, in watching other people. There's things that we learn from social interaction in order to keep us safe and alive, and then again in forming relationships. It is not an accident that the way we think about disorder in our species, many disorders are disorders because of a lack of social connectedness. Something like autism, there is a pervasive social interaction impairment. And I think this sort of speaks to, there may be a sect of people who strongly believe that autistic people should not need treatment, that they are fine just the way that they are, that they are different, and that we as a community and a society need to adapt and understand how to support them in their current levels as opposed to trying to change them. And obviously, I am opposed to anything that is inherently trying to change a human from the core of who they are. However, when we think about this and that social interaction is so necessary for survival and for success, that we would be able to do work to help autistic people be more successful socially in ways that are a bit more naturalistic. And I'm going to explain this. So an old way of thinking is that you identify social deficits for autistic people, and then you essentially teach them those social skills. And I feel like this is trying to teach a child every word in the dictionary rather than teaching them how to read. Because we will never be able to teach every single social skill necessary for somebody to be successful. But what we can do is create natural motivation to pick up learning naturally so that we can start learning these social behaviors in a more natural way and increase social motivation so that they're interested in socialization, in social interaction, and in people. Because when we are interested in something, we're gonna learn about it because we spend time watching, observing, and engaging with it. And so if we can create value in people and in social things, then we're going to just sort of naturally stimulate the ability to learn these things without having to teach every single skill individually. There are a few other lines that I'm going to share from their discussion that I felt like were really impactful.
Where's your eye gaze going in a picture, right? So one of the theories is that people with autism may, at least a subset of them, lack social motivation. So maybe they're not looking in the places like eyes where you receive a lot of social cues that are relevant to social communication.
And I think that this is really important because when we talk about social motivation, again, this goes back to social things, social interaction, and people being inherently reinforcing. We know that we can create reinforcement where it does not exist before. And so if we can understand that like autism struggles with social motivation and motivation is inherently tied to reinforcement, As behavior analysts, we know we can create reinforcers. Then let's do that work so that we can increase natural social motivation, because this is going to be the natural stimulation for learning social behavior.
If a parent has a child with autism, especially if they're young enough that the behavioral interventions could possibly stand a good chance of inducing neuroplasticity, rewiring of the neural circuits that underlie social connection, well, then there's this time-limited window.
And I have been shouting this from the rooftops since I started the Autism Jumpstart channel. We have such a small window of time in order to be able to do the really important work of behavioral intervention that actually changes the brain. Now, when I was a behavior analyst for 20 years, but really without really understanding the brain, we looked at how the environment impacted behavior, and we could use the environment in order to manipulate things to change behavior. And as I've really started to learn and do the research on the brain, it has become so obvious to me the interaction between the brain and behavior. They do not exist separately. They work hand in hand. When we engage in different behaviors repeatedly, we are changing the way that the brain works. And so at this young stage between birth and 3, we have to do a lot less work in order to make significant fundamental changes to the way that the brain works. So why aren't we doing this? Why isn't every autistic child undergoing intensive behavioral treatment between the ages of 0 to 3 in order to help support the development of neural pathways that are underlying social connection? Because they just don't have their diagnoses yet. They don't have the diagnosis yet because there are wait lists to get an assessment. There are wait lists and delays in order to get the diagnosis. There are wait lists and delays in order to get into early intervention and actually get the treatment that's going to help stimulate the brain changes necessary to sort of rewire and retrain the brain for the social connectedness. It's why I created the Jumpstart the Journey course, because it's so obvious to me that we are missing the window for most of our kids. When they finally get their diagnosis, it might already be too late. And it does not mean that the brain cannot change. It can change, and later as they are discussing Dr. Parker's research, there's some really compelling arguments on how to induce neuroplasticity beyond this sort of natural window that kids are in between the ages of 0 and 3.
Ultimately, the goal of improving symptom profiles in autistic kids is about improving social cognition and social behavior. And that process involves rewiring of brain circuits, neuroplasticity. Is there any reason to think that other approaches to inducing neuroplasticity would be beneficial, even if they're not in the biological pathways that are disrupted in autism? I think, for instance, about the now extensive use of SSRIs for the treatment of depression. In some cases it works, in some cases it doesn't. Side effect profiles are a serious concern, as I've discussed on this podcast before. But ultimately, we know that depression is not a serotonin deficiency in most cases. SSRIs or atypical antidepressants like bupropion, Wellbutrin, and things of that sort, when they work, they probably work because of their ability to induce or assist neuroplasticity. Right. Also, the trials on psilocybin are not really about psilocybin. They're about neuroplasticity, at least the trials for depression, right? There may be other uses of psilocybin that relate more directly to the effects of psilocybin. But ultimately, what we're talking about here is the attempt to rewire the brain in a specific way, whether or not it's assisted by oxytocin or some other mechanism.
So again, there are ways that we can probably set the stage for more improved and increased learning for kids by inducing this neuroplasticity to make learning easier, and that there may be some different avenues of research and medication that can be looked at in order to be able to work on this with older kids outside of this very small window that happens naturally from birth to age 3. They also talk a little bit about psilocybin, which is sort of like magic mushrooms, or MDMA. I don't know the full length word of it, but this is like an ecstasy drug. And again, what these drugs do is sort of induce neuroplasticity, which is why they've been shown in research to be so beneficial for treating things like post-traumatic stress disorder, major depressive disorder, addiction, because it's sort of like retraining the brain's neural pathways in a way that would not be possible outside of the window from birth to 3. They make the point that I cannot say loud enough or enough times or post on social media more often than I do, which is a vote for early examination.
If you recruit really young children, you're likely to see a benefit just because the brain is wiring up and it's more plastic at younger ages.
Yeah, that's also a vote, in my opinion, for early examination of kids, right? Like parents really need to get autism screening, and perhaps maybe the most important thing is to make autism screening as available and as inexpensive as possible for everyone, because of the importance of early intervention, even if it's purely behavioral intervention, but certainly if it's behavioral and drug interventions.
But the clinic wait times are really long, right? So you have to have a specialist who's capable to diagnose autism. And so you could have a clinic where, you're showing troublesome features and a parent wants to get their kid into a clinic, and you could have a 12-month or 18-month wait time.
It would be amazing if we could have other ways of screening and detecting autism outside of this very laborious behavioral observation, interview, and assessment, and yet that's just where we are. I actually read an article, I will post it in the show description, that looked at training an AI model, an artificial intelligence model, to study retina scans, so a laser that scans the retina of an eye. And essentially they had hundreds of kids with autism, hundreds of control subjects who are not autistic, studied the retinal scans for them, and also conducted what we call the ADOS, the Autism Diagnostic Observation Schedule. And essentially this is what's used in order to make a diagnosis of autism. So they conducted the ADOS on all of the kids, autistic and non-autistic. And then they had these retinal scans, and they essentially gave 75% of the results to an artificial intelligence computer and allowed it to study and characterize the different results. Then it had AI process the retinal scans from the other 25% of the study participants, and it was able to diagnose autism with 100% accuracy. That means just looking at a picture of the retina, this artificial intelligence could diagnose autism 100% of the time. So I'm very hopeful that we will get to a place where we are no longer at the behest of waiting for diagnostic clinicians to become available in order to conduct assessments and diagnose our kids, because the earlier we can get the diagnosis, the faster they can begin their treatment, and the more neuroplasticity we will have available for effective, significant change to happen. One of the other points that Dr. Parker made that I felt like was so profound, and I got emotional about it.
And if we look in areas where people have fewer access to resource, I mean, particularly in impoverished areas, the mean age of an autism diagnosis is years later than in wealthy areas where, there's many different medical specialists with parents, that aren't working 3 jobs and, can sit waiting around, and really lobby and really advocate for their kids, right? Because, if they don't show up for work that day, they're not going to get fired from their job. Right?
If you are a parent that is wealthy and you have the resources available to you to call 100 places and sit on hold and be on wait lists and go sit in the waiting room with your child while they're getting the assessment, that you will get your child's assessment and diagnosis at a much younger age than if you are a parent that is low income or living in an impoverished place. Which means that if you're poor, your kid does not get their diagnosis until they're older, which means that if you're poor, your kid is going to have lower outcomes. And this is a crime. This is a tragedy that any sort of disorder at all in our world would be subject to how much money and resources you have available to you. It should be non-discriminatory in how we get kids assessed and how we get kids diagnosed and how we get them into treatment. Okay, I'm gonna dive into Dr. Parker's research. I'm not even gonna really show clips from this because I feel like it's so technical and it is so cumbersome to sort of decipher the way that they're speaking that I just want to be able to explain it in a way that makes sense to you, because I watched this whole show with a giant smile on my face because there's so much good research being done and we don't know about it if we're not following it, and most of us are not following what's happening at a research level. But just there's so much promise in the research that's being conducted just with even Dr. Parker's lab, let alone all of the other research labs that are studying very important critical pieces of autism and autism treatment. Dr. Parker studies a hormone called vasopressin. And the way that they describe it is that it's a very similar hormone to oxytocin. So oxytocin is probably something you're more familiar with. This is the hormone that's responsible for a woman's uterine contractions during labor. It's produced when there is lactation. And it's often referred to as sort of the love hormone because it's very essential in creating bonds. So it's sort of what stimulates the bond between mother and child. Obviously, men produce oxytocin as well, but this is one of the most known uses of oxytocin. And oxytocin and vasopressin are very similar in their structure. It's what they call a peptide. I don't really know this because this is not my field at all, okay? But vasopressin and oxytocin are very similar in their structures. I think she said they're like two peptides off from one another. And they're able to bind to the same receptor sites within the brain. Okay, so when I was learning about this stuff in my undergraduate program, essentially when we think about these hormones, they are like, think about them as puzzle pieces, okay? And let's say that vasopressin sort of looks like a triangle, and maybe oxytocin is also like a triangle, but a different shaped triangle. Then they have what we call receptor sites. And these are places that essentially look like they're missing the triangle. They're waiting for that triangle to sort of fit right in. And when it joins, this is when there is stuff happening in the brain. So oxytocin and vasopressin, the reason I'm making this point is because oxytocin is very studied, and yet vasopressin, you've probably never heard of before, but vasopressin is where Dr. Parker's research is being conducted. It's made in the hypothalamus, but there are receptor sites all over the brain. And there's a lot of old research that sort of shows how vasopressin is responsible for social behavior. So she's discussing this research where they are looking at a species, they're called voles, that the males of this species are not inherently bonded to their partner and their offspring. So the male voles may have multiple partners, they may partner and mate with somebody and they have a child together, and they may live like in a similar area, but they don't really have any connection and they don't participate in the child rearing. And this research looked at injecting vasopressin directly into the vole's brain and sort of immediately triggering this bonding with their partner and with the offspring, in supporting the raising of the offspring and protecting the offspring. And so this early research looked at how it could sort of stimulate social connectedness in this animal species. And I want to just talk a little bit about animal research. If you're not somebody who follows research, almost all fields of medicine use animals in research before ever testing out medicine or treatments on humans. And that's just because from a speciesist perspective, the human species is more evolved and more important. And so we need to protect it at all costs. And so we use different species animals in order to test these things to be able to identify if there's going to be adverse effects. And when we think about most of the animal research you probably are familiar with, it's done in mice, right? You hear a lot about mice research. And that's because, crazily enough, mice and humans actually share a large majority of the same genetic composition. Not 100%, obviously, but similar enough that a lot of the things that they're studying can be well documented in mice and have similar effects in humans. Now, there is also a big failure rate when it comes to bridging this research in mice and then it comes to human clinical trials. So it's not an exact science, and it really depends on what it is that we're studying. So Dr. Parker felt very strongly about studying social behavior in a species that had a similar social dynamic as humans. And so she naturally was led toward primates because these are the closest genetic relatives to us. Evolutionarily, they're the closest, and they engage in a lot of highly complex social behaviors individually and within social groups, as humans do. And so this sort of led her to study a population of rhesus monkeys. And what she was looking for essentially was, could we find natural instances of rhesus monkeys who were lower socially, who were presenting symptoms that could look like autism? Now, she makes a point to say that autism does not exist in monkey populations. These monkeys were not autistic, but she was able to identify monkeys that engaged in lower social behavior. They didn't engage in the same types of social behaviors. They didn't engage with the group. They spent more time alone. And so she took this screening tool called the Social Responsiveness Scale, which is something that we can give to humans and rate them on different social behaviors. And essentially, she sort of translated this onto what it would be for monkey behavior, because monkey social behavior is very different from human social behavior. So you couldn't use the same scale, but it could be adapted to study monkey behavior and identify, using a more concrete tool, the monkeys that were lower socially. They observed these monkeys just naturally in their environment. They sort of visually identified the monkeys that were lower social. They conducted the SRS, this adapted SRS scale for the monkeys in the cohort that they were studying. And then they did blood draws to sort of look at some of these biomarkers to see if there was anything that distinguished the lower social monkeys from the higher social monkeys. And then they also did what they call they also conducted a spinal tap on these monkeys to get cerebral spinal fluid. So cerebral spinal fluid is essentially the fluid that coats the brain, and then it travels down your spinal cord. And the reason that this would be important and different from doing a blood draw is that it's the most direct liquid to the brain. It's gonna portray more accurately exactly what's happening at the level of the brain, and that might be something that we're not getting from the blood. And this is exactly what she saw. So she saw that in the blood draws, there was really very little difference in oxytocin and vasopressin between the lower social and the higher social monkeys. However, when studying the cerebral spinal fluid, there was a marked decrease in vasopressin with the lower social monkeys than the higher social monkeys. And why would this be important? Why does it matter? Because if we could find a biomarker, some biological way to identify autism, then we could eliminate what the hurdles are that are holding back most of the kids from getting important treatment at a time when their brain is still in the most plastic form. If we had a biological way to identify it, it could be done in infancy, maybe, and this could alleviate the waiting and the long wait times, the lack of clinicians that we have available to do the diagnosis. It could eliminate the difference in the socioeconomic status and when diagnoses are given to kids. It would be so profound. So she's identified this in the monkey population, but next, can this be replicated in humans? And so she dives in and she gets the data and she looks at the cerebral spinal fluid of a cohort of children, some diagnosed as autistic and some not. And what she found were that the results replicated the monkey research, that the autistic children's levels of vasopressin were significantly lower than the non-autistic children. So there is a significant difference in the vasopressin levels for autistic and non-autistic people. And additionally, what she found was that the lower the vasopressin, the lower the marks on the SRS. So they actually used the SRS for the human population study. And the lower somebody rated on the social responsiveness scale actually correlated to the lower levels of vasopressin. So there's still not an exact finger on the causality, but there is a lot of research to support that levels of vasopressin play a significant role in social impairment. But what this research does not necessarily tell us is the causality, right? So we know that autistic people have lower vasopressin, and we know that the more the social impairment, the lower the vasopressin. But we also don't know, does the vasopressin deficit come from a lack of social input over time? So knowing that autistic kids are less interested in socialization, are getting less social input, have lower social motivation, observe people and spend less time looking at people, is all of this leading to a lower production of vasopressin? Or is it the other way around? That from infancy, a lower level of vasopressin is what is causing autistic children to spend less time looking at people and have lower social motivation. So if you're following this at all, you know exactly where Dr. Parker's research was headed, and that was to look at the cerebral spinal fluid of infants to see what are the vasopressin levels in infancy. Is there a difference? Because if there's not a difference, this sort of shows us that all infants, whether they're autistic or not, start with similar levels of vasopressin, and that it is this lack of social input, social motivation, social reinforcement, watching people. It is this that is causing a lower output of vasopressin in the future. But if the vasopressin levels are different at infancy, this would lead us to believe that there might be a way for vasopressin replacement therapy as an option for treatment. And so she got to the infants. And let me just tell you this. I encourage you to go and watch the Huberman Lab podcast about this. If you're a science nerd at all, you would love the whole episode and the way that she explains how, sort of the progression from rhesus monkeys to human population to infants. And I felt like I was watching a movie, like the anticipation was building up, and I had this huge grin on my face when she's now talking about sort of getting to this point in her research. So she connects with another scientist who, she said, the scientist had what they considered liquid gold. So this scientist had this freezer that could keep samples at this incredibly low temperature. He had this giant collection of infants' cerebral spinal fluid that had been taken for a different reason. And it had been taken for a different reason, obviously under a medical condition that they had to pull the spinal fluid, and then it was just sitting in these freezers waiting. And Dr. Parker was thinking, okay, if I can get my hands on this spinal fluid to test, and the samples were from years ago, which mean that these infants are now children, and we would know whether or not these children now have a diagnosis of autism. So she gets to use the samples of cerebral spinal fluid from infants, and she gets to study the vasopressin levels. Then she gets to follow these children and see which of these children went on to receive a diagnosis of autism. And you want to know something? The children that had autism had lower levels of vasopressin in infancy, which means that it is most likely present from birth. And the implications of this are so huge, because not only does this now give us a biomarker potentially for autism or a certain sect of autistic people, she makes it very clear that there's no way to know that this is going to impact or be the same for every autistic person. There may be a subset of autistic people with this lower vasopressin, but it gives us an identifiable biological change that we can look for easily starting in infancy to be able to show us what kids are on a path that might set them on the stage for autism. What kids might be available for a very early behavioral intervention in order to take advantage of brain plasticity and sort of rewire the circuits underlying social connection. But obviously, she also wants to see whether or not giving vasopressin as a supplement can increase or improve social behavior in autistic children. So her next research looked at children ages 6 to 12 and essentially had an autistic group and she had a non-autistic control group. It was a double-blind study, which is sort of the gold standard in research, which means that neither the families or children or the researchers knew which kids were getting the vasopressin and which kids were getting the placebo. And they did this for 6 weeks. And they did a baseline SRS, social responsiveness scale, before any treatment. And then they did a post-treatment SRS follow-up to see if there were any changes on the social responsiveness scale. And what they found were that the kids that did receive the vasopressin had marked improvements on their social responsiveness scale following the 6 weeks of treatment.
Scientists like repetition. And so we had parents fill out their impressions of what the child's behavior was, before and after being on the medication. We also had a clinician make an evaluation, but we also had the kids perform laboratory-based tests where they would see, like I mentioned, that the reading the mind in the eyes test, or we would show them a picture of a face and say, what emotion is this? And so we were able to have what's called convergent validity, right? So it's a fancy scientific term to say, do all these measures that we think should be related, are they related, and are we seeing the same thing? And the answer was yes, so that when we gave children with autism vasopressin versus kids with autism a placebo, the kids who were treated with vasopressin showed increases in social abilities on parent report, clinician evaluation, and child performance on laboratory-based tests.
Wow.
Not only did they have improvements here, but they also had improvements just based on parent report on how social the kids were being.
We did have an article that Stanford Medicine, I can send you the link. They were able to, I think, interview a family that had been in the trial. And so obviously there's patient privacy, and they have to say it's okay to talk about it. But this is a family that was contacted. I think they were anonymous, but this is in this report. And they basically said, the dad said that his son was walking around he was on vasopressin, and his son was walking around a grocery store, and he was looking for him. And he turned around and he said he was gobsmacked because his child was, just making chit chat with somebody in an aisle. And he said he had never seen that happen before.
In terms of what exactly is happening in the brain that is improving the social behavior as a result of the vasopressin, Dr. Parker still doesn't quite understand or know yet. But she thinks that there's something about improving social motivation, which goes to being able to create more value in people and in social engagement, having it be more reinforcing inherently so that kids are more motivated to want to engage socially. And there's this beautiful quote that she gives.
So we don't know the mode of action, but then our feeling is that, at least from the initial safety data, it looks pretty safe. And so the idea would be, and there's a long tradition in psychiatry of, we don't know the mechanism of action, but if we have a medication that can be impactful and improve the lives of people with autism, and we can diminish suffering and people can more readily reach their full potential, to me, it actually seems unethical not to move forward in a way that's scientifically sound.
Amen to that.
And I love this quote so much because essentially as a scientist, you want to understand all of these mechanisms. You want to really understand why something is working. But as a clinician, as somebody in the practice of helping autistic children and their families, you want things that work and you don't care why it works. You want something that has an impact regardless of your understanding of why it has an impact. And so she's on her second replication study of this vasopressin supplement. She's doing it with a larger population of kids just to make sure that the validity is there, that it does impact a larger portion of or larger population of autistic children. But essentially, she's incredibly hopeful about the idea of vasopressin being able to be used and administered in order to increase and improve social behavior. And then there's one final sort of discussion about the microbiome or the gut. And so if you are a parent of an autistic kid, you're very well familiar that there are often gut issues that autistic children often struggle with gut issues. And I really enjoyed this conversation because I was not very familiar with the microbiome and just this the gut and the brain connection. And I don't know if you've heard this, but people often talk about your belly or your gut being your second brain. And if you don't understand the nuance of the brain, this can seem incredibly silly, but what they describe is essentially this connection via something called the vagus nerve. And the vagus nerve starts in the gut and it sort of ends in the brain. And Dr. Parker actually described a research article that looked at levels of oxytocin and vasopressin pre-treatment, and then as the treatment provided kids with probiotics, which essentially a probiotic is simply a way to diversify the bacteria in the gut. And what we know is that the gut needs a lot of diverse bacteria in order to be very healthy. From a gut perspective, just in terms of having, your stomach working well and having bowel movements and being healthy in your gut, but also now understanding the gut and the brain connection, they were able to see that there was an improved level of vasopressin being produced in the brain as a result of a daily probiotic. And they were able to confirm these results because they were able to dissect the vagus nerve and essentially block it from being able to transfer and transport anything from the gut to the brain, and giving the probiotic to these people who did not have this gut-brain connection. There was no elevated improvement in the vasopressin that's being produced in the brain. So it implicated the vagus nerve is incredibly important in being able to sort of communicate the from the gut to the brain and improve the level of vasopressin that is being produced in the brain. I think this is really important even just for parents that have kids who are looking to sort of help things, because getting a vasopressin supplement is not something that you can do today. It's not like you can go and ask, it's a nasal spray. You can't just go to your doctor and ask for a vasopressin nasal spray, but you can go get probiotics. You can get a dietary probiotic and give that to your kid on a daily basis. And this is research that's actually showing the connection between improvement in the gut biome and an improvement in the production of vasopressin. And there's so much research that was already talked about that shows that vasopressin plays an important role in social behavior. So that's sort of the end of the episode. I know that it was a lot to digest, but I felt like it was so important and it was so interesting, and I wanted to be able to explain it in a way that I hope was easily understandable from a population of people who aren't scientists. Dr. Huberman's whole philosophy is bringing science to the masses. I think it's such a valiant mission. I think it's so important for us all to understand how science works so that we can evaluate things that we want to do for our own selves or our children and know that we're not going to be doing something harmful because we're able to read and understand science. So I hope that this was really helpful and insightful for you. If you have questions or comments, leave them below. And until the science brings us to a place where we can do a blood draw and see if a child is autistic or induce neuroplasticity in a way that is unnatural, please take advantage of your child's natural neuroplasticity in their earliest years of life. Be aware of the signs to be watching for. Be aware of what neurotypical development looks like so that you can see when your child is not developing that way. Please seek out resources to start working with your child at a time before you may have their diagnosis in hand, because who knows when that's going to be. That's why I created Jumpstart the Journey. That's why I feel so passionately about informing and educating parents so that they can take matters into their own hands. They can be empowered to actually start their child's progress on their own without needing to wait for professionals to finally get them off of a wait list and start their treatment themselves. So thanks for joining along, and I look forward to seeing you in the next one.